Welcome to another episode of Let's Talk Small Data with T, where we are passionate about the power of small data in healthcare. I am your host, Tanazia Gonzalez, but you can call me T. Data has certainly changed the game in healthcare. Big data has blown the roof off, but small data, now that's the future. Small data allows us to dive deep into the key insights and take quick, customized action to achieve phenomenal results in performance and quality improvement. Let's explore this today. Thanks so much for joining us. If you have any questions for me or any of my guests, feel free to reach out to me at tgonzalez@eima-inc.com. Enjoy the show. Let's go. Welcome to another episode of Let's Talk Small Data with T, where we explore the power of small data in healthcare. Thank you for tuning in, and today we're going to be talking about small data and the HIE, or the Health Information Exchange. I'm really excited for this show. Today I have Tom Moore, who is the Senior Vice President of Innovation at Healthix. It's the largest HIE in the country and probably the largest one on the planet. I have to get confirmation on that one, but I'm pretty sure that's it. Tom has worked in information technology for over 20 years. He works closely with Healthix members to define and design information services to support improvements in care coordination across disparate organizations. And I'm really excited to hear what Healthix is up to with the data that they have access to and really how they're leveraging their small data to really improve lives, because that's what this is all about. So Tom, welcome to the show. I'm going to ask you to put on your camera so that we can start the discussion. You should be able, there you are. Hello. It's been
Nice
a
to
long
see you,
time.
T. Yes,
How
it
are
has.
you?
I'm great. It's good to
Thank
see
you
you.
so much. Yeah, thank you so much for joining me. You know, I'm a huge fan of Healthix and the HIE in general, but I remember I still speak as if I'm still there because I do feel like I'm part of the Healthix family, but
You're an
yeah.
alum.
Thank you. Yeah, so Healthix, quite large. Is it accurate that it is the largest HIE in the country?
Um, yes, there are different ways of measuring things, of course, but we're going to go with yes. And
Okay.
you had an interesting comment about largest on the planet.
Yes.
That's harder to validate, but
No.
I do know that we're larger than the entire nation of Sweden. So that gives you an
Wow.
idea.
Okay.
And to be fair, a lot of that is because of the size of New York City, the greater New York City area, right?
No, very true. Very true. It's a lot of folks.
Yeah.
So I guess we can go ahead and open up with tell us a few words about you, your background, you know, what your passions are. I'm really interested in talking to my guests about their interests, especially where it relates to data and usage of data in healthcare. And then you can just tell us a little bit about what does HIE mean exactly? What is an HIE? And that's what
Okay.
Healthix is,
Sure.
just so that we can understand that.
Sure. Well, I didn't, as a young man, I didn't go through college thinking I wanted to be in IT. I studied sociology. I was interested in communities. And
Okay.
I, somewhere along the line there, I got interested in IT. And that led me to various careers in IT. And I've done lots of different things. I've done programming and project management and data analysis and business analysis and kind of everything along the chain.
Mm-hmm.
But I and I also, by the way, went back to college. I got a graduate degree in public administration, and then
Okay.
also kind of abandoned public administration and went into working for corporate America. But I winded up at Healthix and found that I was really had come full circle because what we do is really
Mm-hmm.
community oriented, and it's very public administration oriented. So it's kind of it's funny how life goes around like that.
Right.
It's very much an IT thing as well, as you know,
Yes.
but our purpose, our mission, really has to do with making New Yorkers healthier. So
Totally. Oh, I love that. And for my listeners who don't know, I used to be a senior project manager at Healthix. So that's what we're referring to when Tom says I'm an alum. I mean, I've always been a huge fan of what the HIE can do. I know it's presented with many challenges, but what you guys are doing is changing lives and making things easier for the providers to be able to manage folks. Um, so, what is an HIE? Really, let's just clarify that for the listeners who are not aware.
Okay, so HIEs started up probably 20 years ago, but they started to really come into their own in this last 10 years. Basically, the concept is to create an organization that manages interoperability between healthcare providers. So think of us as a big hub. Everybody sends their data into us, and everybody on the hub can get their data out. But the magic is that they not only can get their own data out, but when they send it into the hub, we link it up to all the other places where their patients have had care. And in New York City, with a dense population and a large number of patients with complex conditions, we
Mm-hmm.
have a lot of cases where people are going to 2, 3, 4, up to 10, 11, 20 different providers.
Mm-hmm.
As you know, a lot of people go kind of around to the different hospitals and
Mm-hmm.
EDs. So there's there's a lot of need by providers to know where their patients are going, and that's the problem that we solve essentially. Uh,
Totally.
yeah, so we have about 28,000 different organizations connected to us. These include
Wow.
hospitals, post-acute care, physician practices, obviously, and health plans. We have about 18 health plans that are connected to Healthix as well. We're moving a lot of data, as we talked about before. On average, we bring about 4 million records in per month, and send out about 7 million alerts to folks about what's going on, with their
Yeah.
patients in the network. And there's a lot of different things that we do. We probably don't have a time to talk about all of them, but they all generally fall into the broad categories of clinical care,
Mm-hmm.
population health,
Mm-hmm.
public health, research, and consumer engagement, I should say.
Nice. Um, so it's terabytes of data, right? Very
Oh yeah,
big data applications, big data processes have to be in place to make sure things are managed properly. Um, and pretty much one record for one patient. So my if I'm a doctor and I'm managing these patients, I want to know where my patient has gone to. You can also see medications prescribed and services, right?
right.
Is New York State still an opt-in rule or is it now opt-out?
Yep, New York State is among the most restrictive states in the country because of the privacy policies that we have.
Right. So,
So all the data flows into us pretty much without condition,
mhm,
but we're very restricted on how we can let the data out.
right.
Well,
Patient
no,
or the
we
HIE.
get it, regardless. But when
Okay.
your doctor goes in and says, "I want to pull
Care.
T's records
Okay.
out," they
Right.
have to have your explicit permission to do that.
To be able to do that. Right. Okay. So I've been on the other side and I always smile every time I go to a provider and they present me with the documents and I'm like, whoa, there's a lot of stuff here. But, I understand what this means, so I always click yes, allow. But I'm sure you guys have run into issues where it's patients aren't really sure what this means and they're scared of everything, so they deny. So it must be a large number of records that providers can't get access to because the patients haven't given permission for that yet. So,
Yeah.
right.
So you know how sometimes driver's license will ask you whether you would like to let your organs be used in the event of your
Uh huh.
death,
Yeah.
organ donation. In states where you're asked, you have to take an action to say
Yeah.
yes, it's okay, you can use my organs. The compliance rate or the opt-in rate is very, very low. In
Mm,
states where you have to take an action to say no, do not use my organs in the case
right.
of an accident, the opt-in is very, very high. And so we have the same issue. If you're
Mm,
asked, you don't tend to answer. But if you have to take an action to stop the permission,
Okay.
then it's very high. And that's what most of the country does. The most of the country says we're going to share your records unless you go to the trouble to tell us, no, I don't want you to do that.
That's called opt out,
Right.
right? Okay. Very good. All right. I know it's all in the spirit of protecting privacy and all of that, but sometimes it prohibits you to really change lives in a positive way.
The
So
trade-off.
yeah, the trade-off. So I know you guys are dealing in some very big data tools and application. My love and interest is in the small data and what you're doing to my husband calls it itty bitty numbers. I say no, that's not what we mean by small data. It's really an action. It's being able to drill down and really identify and work and move the numbers, move some metric. So, do you all have some specific initiatives that you're working on, maybe with participants or members or partners, um, in the spirit of using or leveraging small data?
Yeah. Well, I was right there with your husband until generously gave me that information and kind of educated me about what small data is.
Uh-huh.
And when I read it, I was like, aha, that's exactly what we need to do. That's
Yeah.
exactly what we try to do in many cases.
Yeah.
So you're absolutely right. Having a large amount of data is a double-edged sword. It's
Hmm.
great to have it. We're very happy and proud of the fact that we get so much data from so many different organizations. But then when people ask for it, they are it's not very useful necessarily. So if, for instance, if you pull up the record of an elderly patient with a complex health history, you could easily get a 100-page document. So now, you've got a busy day. Is that really useful to you in the workflow? If you just had one patient, fine. But if you've got a busy day, lots of things to do, what are you going to do with that?
Right.
The other example of that is we started quite some years ago sending out alerts, letting people know, hey, your patient went to the hospital. Hey, your patient's leaving the hospital. They had emergency visits and so forth. And that was really exciting. And to say, oh, this is great. So we just went crazy and everybody gets these alerts now. And recently people have started complaining about too many alerts. They're clogging up their inbox and, I can't go through all this stuff. So
Right.
these are two examples where small data really comes in. How do we get that information, that huge body of information, down to something that is useful and, as you say, actionable?
Actionable.
Um,
Hmm.
yeah. So that is a perfect way to describe what we are trying to do now. And I can give you a couple of examples if
Yeah,
you'd
that'd be
like.
great.
Well, one of them is let's start with the clinical alerts. Okay,
Okay.
so clinical alerts right now are pretty, from my perspective, now that we've been doing it for a while, pretty simplistic. If a patient goes into the hospital, either on an emergency or an inpatient visit,
Hmm.
we detect that and we can tell their, say, primary care provider or
Hmm.
their nursing home or their health plan.
Hmm.
Same thing when they leave. And that generates a lot of stuff. And then there is value in that sometimes. But what we found is, let's take an example. Entering the emergency room. Yes, that's important. Need to know that happened. When they left the emergency room, not so much, because it's going to be sometime that day, right? If
Right.
they leave that day, then they're going to be admitted. So
Right.
but we send a discharge from ED. And so, that's an example of something we could do. But the really much more interesting part of alerting is when we are much more nuanced about what triggers it.
Hmm.
So rather than just finding out when they go to the hospital, how about find out if they went to the hospital, and based on the diagnoses of that visit, we know that encounter has a high likelihood of leading to an avoidable readmission.
Yeah.
And that's a very doable thing. And we've actually implemented that by taking the CMS rules. They already publish the
Hmm.
diagnosis codes that tell you that if a patient admits with this, they have a
Hmm.
high, and this is based on data, right?
Hmm.
So I'd rather send that, and that's a lot fewer alerts, right? A lot
Yeah.
lower number, a lot higher value.
Right.
We've also done things like checking for HIV patients, checking the viral load. If the viral load pierces a certain level,
Right.
that's it could be a yellow alert. It could be a red alert. It depends on how high it is. So we
Okay.
work with HIV clinics and let them know when their patients are not in care and are
Hmm.
in dangerous shape with their viral load.
Very cool.
Um, we also recently figured out a way to detect when a person's homeless, and we can alert on that basis as well. And homelessness is not, it's not as easy to determine as you might think. People who are homeless don't necessarily have that on their record. It's not in the record explicitly. So we have to rely on some like interpreting the address. If the address is
Mhm.
a hospital, for example,
Yeah.
or a place of worship or someplace, we've identified all of those locations that
Mhm.
are essentially a proxy for homelessness. And that's how we identify that. Um, we also did some work with the state on identifying people who are HIV positive and have fallen out of care, and
Okay.
detecting that they're not in primary care, they're not getting their checkups, they're not getting the lab tests and that kind of thing. And then
Okay.
we can advise either the primary care doctor, or if they happen to go into an emergency room that has an HIV clinic standby, rapid response team of some kind, we can say, hey, there's somebody in the ED who's fallen out of care, they really need to get some coaching and so forth.
And not really connect it.
um,
Connect it. Yeah.
yeah.
Pretty
So
cool.
there are some other examples, but that's how we can kind of get the alert
Hmm.
flood down to a narrower group, again, lower volume, higher value. And
Yeah.
I think that's a good example of a small data principle.
No, I love that. Yeah. And I remember with the clinical event notifications, right? The CENs, it could be alert.
Exactly.
Yeah, the alert fatigue. And it's really
You got it.
important to, while you guys are drilling into, the alerts that you're making available on the provider side, they need to understand, okay, when we get these alerts, this is the process. This is who's going to take them in. This is who will triage
Right.
them. And they need to have that whole
That's right.
process set up on their end. And with both activities, that helps to really narrow it down so it can really create some real value where they could take
Yeah.
it and act fast. Um, so the interesting thing is, I love the identifying the homeless. Once you have, hey, we have these 100 patients or 100 people we feel may be homeless. What do you do with that information? Who gets that?
Well, yeah, that's a good question. I mean, right now we have the marker on their record that they are homeless. We keep track of that again based on where the address is given. We've used that to send out alerts that your patient has become homeless. So that means that they're at risk. You
Okay.
might want to be looking for them showing up in the ED, because that might be the only way you can get in touch with them.
Right.
Um, the ED itself could be a good recipient for those alerts. Just say, hey, the person in your waiting room is likely to be homeless. So just keep that in
Okay.
mind when you're caring for them, that they might not have a good continuity of care
Okay.
after this visit. But the other is we can just run reports. We could say how many of which of my patients are currently homeless,
Right.
and give that report out on a regular basis.
That's interesting. Yeah, because you have data. You have data in the system. Do you know going back to what date right now? Do you know what date,
Um,
like, what's the earliest year?
I think the earliest year was 2008.
Interesting. Okay, so you could see the story, like, right, the full story. So you said something that triggered in me. I didn't think about that. Like, you have a bunch of patients. Oh, hey, these 10 patients may now be homeless because of these particular indicators. So you may want to engage or, intervene
Right,
or do something, especially if they fall into the chronic condition buckets, right? Um,
right.
yeah, no, that's pretty cool. Um, so you said something earlier about the readmissions, being able to potentially predict the patients that may be on their way for a readmission. So it's kind of predictive analytics, right? Do
Exactly.
you
Mhm.
all have a predictive analytics tool that you're now using, or is it just like we have these diagnoses that have been reported to us by way of CMS that indicate that this may happen? And so because we're seeing this on this side, this may happen. Or do you have like a predictive analytics application sitting now on Healthix's data source working along with you? I hope that
Right.
wasn't too
We
loaded.
actually have no, that's actually a good lead in.
Uh-huh.
We actually have both. We took
Nice.
the CMS rules right off their
Okay.
website, and we just hand coded them into our triggers so that we know when those
Okay.
things happen. So
Trigger
that's the
alert.
kind of the low tech approach. The high tech approach is we have partnered with an analytics predictive analytics vendor. This is a group out of Stanford, mathematicians and health
Okay.
informaticians, and they've put together predictive models for 20 or so different conditions, all
Okay.
of your typical chronic illnesses, diabetes, chronic heart disease, respiratory
Yeah.
failure, et cetera, et cetera. So they've got models to detect the risk of
Mm-hmm.
any of those person getting any of those conditions, plus things like readmission or ED visit or even death. So
Wow.
it can be actually be used to try to get to somebody before they die.
Totally. So I've been talking to people, Tom, all over the globe, about this small data thing and the different things
Yeah,
that folks are doing. And that's one thing that always comes up, the predictive analytics, trying to identify and identify groups that we need to intervene with faster, sooner than later, especially folks who are at risk for readmission, but mortality, like death. Um, and so there was another gentleman that I interviewed. He was saying, we are stuck in a rut. We're doing things backwards. We need to be a little more proactive. And speaking of the systems within the providers' offices, instead of looking at things retrospectively, we need to be looking at them proactively. So as the data is being created in the system, his tool sits on it and says, whoop, you just entered in XYZ for this particular patient, may be on his way to death within this time period or whatever, not in that way, but like pretty
yeah,
much doing predictive analytics on the spot
yeah.
rather than retrospectively. And I know that you all are working with claims data. You're also working with data coming in from actual encounters like happening in real time.
Right.
Um, so
But
you can
that's
use
very
it
cool
both
that to the idea that you could detect it as you're entering the
as you're
data, the
doing,
patient's still in your office. Yeah,
right?
that's very cool.
There's another group that I've been working with called Precision Health, and they're developing AI tools that take those gigabytes of data. You just said, from one patient, you can get 100 pages. Who has time to sit down and look at all of that data, all of those pages? What it does is it captures like three key markers, identifying
Oh,
information for the patient, the date and time, and some activity, and creates a
yeah.
profile and is able to run statistics right there on the spot for the
Huh.
provider and give alerts right there. Like they call it, it gives you the next best action for each patient. Like, this provider, this patient may need a call right now. This patient may need a new prescription right now. I mean, just different things like that. So
Well,
thank
T,
you
you
for.
should introduce us.
No, I definitely will. And actually, I like you said community earlier. So what I've noticed is that in developing this small data community, a lot of folks who are very interested in this small data thing, we're all
Mm-hmm.
coming together, talking about it and mind melding. And there's a lot of synergies that
Yep.
I see could come out of this. And I'm creating a community where I bring all of you into one place where you can see each other, communicate with each other, interact with each other. There are a number of different organizations that I'd love to introduce you all to.
Well,
Um,
I have a feeling you're going to do it because I saw what you did when you were at Healthix, putting that annual symposium together.
oh
Tell you,
my
we've
goodness.
never had anything since then. I think about that all the time.
Yeah. And God rest his soul. Shout out to Stephen Keating, right? He
Right.
was definitely preaching access to data, especially as the patient accessing data. You said something about consumer engagement.
Right.
You can't get any smaller data ish than that, right? Just being able to
Yeah.
give each consumer access to his or her own data so he or she can see her whole story and say, hey,
Yep.
this is what you look like to your provider, and just be able
Yep.
to introduce that into the discussion. What do you have any specific, I know this is a little bit off the agenda, but do you have any like specific initiatives or programs that you all are doing to address consumer engagement?
Yeah. So we have two vendors who have patient-facing applications on the phone. One of them is an EHR, and they make it available to their providers can make it available to their patients,
Okay.
and that's a conventional personal health record. So if
Okay.
you if they can verify that the person is who they say they are, and they obviously they can do that in the doctor's office,
Right.
then we can open up access to the record, and we're doing that for I think quite a few thousand people now. It's small relative to the number of people we have, but it's a growing thing.
Nice.
The other one is much more specialized. It's specifically for a person to get a COVID-19 uh, passport. And
Okay.
so they're tapping into Healthix, where we maintain millions of test records, test results, and
Yes.
vaccination records. Um,
Right.
Not only do we have our own vaccination records that we collect from our providers, but we are able to tap into the city's immunization registry.
Nice.
So some of these small outlets that are doing vaccines, like drugstores
Mm-hmm.
and urgent care, who aren't connected to Healthix, will be getting those too. So we should pretty much close all the gaps in the vaccination data through that. And then we can
Right.
this app will allow you to anywhere you go to say, hey, I'm I'm COVID clear, and it comes from a reliable source, and they
Right.
have a patient identity verification process they go through.
Very nice. Very nice. That's really
Yeah,
cool. Yeah, I understand that, that's like first stop. This first step, verification. You are who you say you are. Sometimes that's
right,
like deal breaker right there, and that will break the chain. But once you get beyond that,
right.
the sky is the
We're
limit.
we're
Yeah.
pretty we're pretty careful with security, and the state in its haste put out this application that you can use to get your vaccination record, but there's really no real security on that. Anybody can, if I knew a couple of things about you, I could get your vaccination record from it. So
Okay, so it
um,
just tells you if I'm vaccinated or not, right? Is that all it
right.
offers? Okay. Pretty
Yeah, I think it's just a vaccination lookup. I don't know if it gets
okay.
test results.
Okay. Okay. Yeah. So I was just, for some reason, I thought in my head also about the Social Security Administration. They know who has deceased and who hasn't yet, as far as what's in their records. Do you guys have, are you tapped into them as well for like mortality, or you rely on other sources to know if a patient is deceased?
Um, right now, and this is another privacy concern, the only mortality information we have is on patients who die in the hospital. And then we get a record. There's a standard message that comes across when a person expires in the hospital.
Right.
We are starting to get information from state registries, but they're very cautious about it. They're very careful and cautious about sending us that information. So
Yeah.
it's not as open as we would like it to be,
Mhm.
but because it's really important, as you can imagine, if you're taking care of somebody and they die, you can spend a lot of time trying to do follow-up and care
Right.
coordination on them. So
No,
letting doctors know when their patients die is important, and I think we'll eventually get there.
okay. Yeah, no, totally. That's good stuff. You
Yeah.
also mentioned when you were talking about the alerts, like a patient goes to the ER, you can get an alert for that. But when they leave, not so important, right? And then I was all of a sudden thinking in my head, people can go to the ER, leave, go to another ER, leave, go to another ER, the drug seeking population. And then all of a sudden, the opioid issue in this country popped into my head. I've spoken with a number of other folks dealing with this as well. Would you say that does Healthix have any specific initiatives tackling that issue?
So a couple of things. We it's pretty easy for us to identify which patients are frequent ED utilizers. And by the way, just to be fair, there's a lot of different reasons why people go to
Hmm.
the ED frequently. Some of them are truly in severe chronic pain
Yeah.
and are having trouble getting service. You know, sickle cell, for example, it's very
Hmm.
widespread, and a lot of people don't have good care,
Right.
either because of, for whatever reason, and they are in a tremendous amount of pain. So a lot of times they go to EDs and they're looked at as seeking pain relief, but actually they're just trying to manage a very difficult disease.
Mm.
But you're right, there is a lot of opioid misuse, and there's a lot of mental health issues
Right.
as well in the EDs. So we can detect those, and we have reports on that we can give to facilities. Say, these are the patients that you're taking care of who are hitting the EDs two,
Hmm.
3, 4 times a month,
Hmm.
and that some people find that very useful.
Yeah.
They can derive it from the alerts they get from us, or we can just give it to them as a report.
Okay, very nice. I mean, if
But
in any event, if you're continuously hitting up the ED or you're a frequent flyer, as I unfortunately always use that term and then get my hand slapped. But
I promise not to.
frequent flyers of the ED, which, hey, I'm a lover of people. When I see that happening, something's off. So you
Yeah,
can, I alert the providers, these folks have been, you know, have this particular activity going on. You might want to engage.
right.
Something's up.
By the way,
So,
just on that note, the other thing I wanted to tell you, T,
mm,
is that we recently started partnering with a vendor called Collective Medical, and they
collective
do
medical.
something Collective Medical. They do something very interesting.
Yeah.
They take the Healthix data when the patient walks into the ED.
Yeah.
They pull that in, and they do all kinds of like analysis on it, and then
Wow.
they deliver a message directly into the ED that goes into their track board so that they can't miss it. That tells them important things that they might want to know about that patient, and one of them is either mental health issues or opioid use, and
Okay.
they can find out that right away. Another thing that's actually really key that they do is they identify people who have a history of violence, and that's a big issue in the ED. So this is really valuable to ED
Yeah.
staff to know that that guy sitting over there that you're about to take care of, he's got this background, just so you're prepared.
No, totally. Yeah. No, that's awesome. That's awesome, especially with the large amount of shootings we have going on in this country right now. One just happened right here in my neighborhood.
Oh my God.
So yeah, I'm in Malvern, Long Island, Nassau County. Tom, right now you're in Manhattan, right? New York City.
No, I'm
Well,
right
Healthix,
now I'm in
Healthix is in
Dutchess
New York
County.
City. Okay. I know it's COVID, right? COVID lockdown, pandemic-ish type of arrangement. So we're all over the
That's
place.
right.
Yeah, but
That's me.
Healthix is actually located in Manhattan, right? Are you
Correct.
still okay? Very nice. In a very cool area, which I miss dearly. Um,
Yeah.
so do you before we come to the end, I would love to hear. I was looking at the website and I did see a number of like success stories. But do you have any success
Okay.
stories directly tied to any of these small data initiatives that you'd like to share, like impact on a particular patient or population or participant that you're working with?
Well, COVID was, especially the beginning of the COVID pandemic, the outbreak. All of us were really called to duty, and we were really pleased to be able to jump in with both feet.
Mhm.
So first thing we did is we detected every COVID test. Of course, there was no vaccine, but every COVID test and every COVID test result, and sent them directly to anybody who's taking care of that patient. No
Okay.
questions asked. We didn't take the time. We didn't have the time to consider whether somebody would want them or not. And the state Department of Health was wonderful. They said, policy be damned. This is important. Let people know. So that just immediately went out with no policy barriers. We also started providing huge volumes of data, relevant data to the health authorities, both at New York City and New York State. All the anybody who was COVID positive, all of their hospitalization data, so that they can use that and try to make sense out of it and prepare
Right.
for it. And then, of course, now with the vaccine, as I mentioned, not only are we collecting our own vaccination data, but we're able to tap into the um, New York City citywide immunization registry and tap that for vaccinations that we don't collect. So
Sure.
that's probably one of the big success, really current success stories. As I think we've always done a lot of work in the HIV area,
Mhm.
and as I mentioned, we're able to detect people who are lost to care. We're working closely with New York Presbyterian, the Alliance for Positive Change, and Housing Works to
Okay.
take those patients and detect when they enter emergency room, and then
Right.
they can actually have a rapid response, try to get that person back into care.
Mhm.
Do a similar thing with the Office of Mental Health, where somebody is in a mental health treatment and they stop showing up. And
Okay.
that's what they call euphemistically unsuccessfully discharged.
Okay.
And that means they basically just left. And
Okay.
so we detect when they pop up somewhere so that
Okay.
they have an outreach team that will try to re-engage them.
Very nice.
Um, Now, on a very different note than the care coordination, we also have sort of a business function. As you know, value-based contracting and payment is a hot topic, and
Oh yeah.
we're starting to work more and more with our providers to help them close gaps in care
Yes.
that will then allow them to report quality metrics, receive
Mhm.
higher scores, reimbursement, that kind of thing. So we recently started working with one of our large hospitals that takes a large number of patients on at risk and provide them with closed gaps in care that then allows them to up their rating and significantly reduce the time that they spend trying to track down these metrics that were already met unbeknownst to them.
Yes. Yeah. Yes. No, that's totally. That's awesome. I'm a big fan of VBC. I live it and breathe it every day. I also had an opportunity to work with my own hands with your COVID alerts that you all was sending and
Oh, wow.
identifying out of our population who had a test and who's positive. And out of the
Yes.
positive, where are they in terms of condition?
Right.
Because I know that we had to really understand, okay, who's currently in-house, who's inpatient right now.
Yep.
And because of that, we need to be very mindful of what conditions they fall into. Are they a diabetic? Are they this? Are they that?
Yeah.
Because the
That's
COVID,
great.
yeah, and the chronic conditions were really, yeah. So definitely it was very valuable information and really helped us drill into a population and really track and monitor. I went nuts. I went nuts with the alerts and I was going, ooh, Healthix alerts. I know all about these. So no, good stuff, Tom. I really love what you all are doing, and it's definitely a lot more work to be done, and so much more to be done on the VBC side, with
Yeah.
closing the gaps and essentially improving the quality of care and changing lives, right, of the patients that we all serve and look out for. So,
Yeah.
thank you so much for all that you do and all that you all do at Healthix. HIE, which I will maintain is probably the largest HIE on the planet. Um,
Let's go with that, T.
that's it. Well, thank you so much for being on the show. And I'm looking
Well,
forward to connecting you with the Let's Talk Small Data with T community coming out soon. I mean, you all will be made aware of that very soon. I'd love to have Healthix and possibly Todd and some other folks on a live show talking
yeah.
about some of the things that you all are dealing with or managing or getting into and be able to interact with the audience.
Yeah.
So and take
If I
questions.
know you'll make it happen.
Yes, we are doing this. So thank you so much.
Well,
And go ahead. What were you going to say?
I appreciate you bringing me in, and I appreciate your passion for this.
Thank you.
It's really inspiring, and I'm sure this is going to be a great thing. So
Thank you.
go
Thank you.
for it.
Any
Good.
last words before we close the show?
I would just say that small data is definitely the way we should be going, the way we should be thinking. We've already figured out how to acquire a lot of data. Now we have to figure out a way to make it really useful and actionable, as you say. And That's going to be an ongoing process.
Totally.
But I'm happy that we're starting to get on that path now.
Excellent. You said it well. Thank you so much, Tom.
All right, T.
Bye.
Take care.
You too. Thank you for joining the show, and I really hope that you enjoyed listening to my discussion with Tom Moore from Healthix, the HIE. They are currently in New York City, and they're doing some great things with small data and big data and really changing lives, and that's what this is all about. To my listeners, you can subscribe to the podcast by going to Spotify, iHeartRadio, TuneIn, or you can go to www.eima-inc.com and click on Let's Talk Small Data with T. And if you're interested in being on the show or would like to connect with any of my guests, feel free to send me an email at tgonzalez@eima-inc.com. And this brings us to the end of the program, and I want to say have a wonderful day, and remember, unleash the power of your small data. This episode is brought to you by Effective Information Management Systems, specializing in healthcare small data and offering expertise that goes beyond technology. Visit www